can't meet, so I'm doing the presentation today. This is my first Zoom experience, so sorry for the delay, right? Okay, so I'm going to talk about, can you see me and hear me clearly, right?
Yes, sir.
Okay, so I'm going to talk about a topic that we decided to speak upon due to a patient that we got. So, basically the topic is falling in the elderly population. So what we are going to talk about whether it's a problem and what we can see and what we are going to do about it. So the thing about falling in elderly patients is it's a very common thing. It's more common than we really expect, and it is a preventable problem, and it costs a lot of money and a social issue and a lot of personal problems for the patients. And the other problem is that it has very poor outcomes. The complications of a fall in an elderly population, that is somebody who is above 65 years, causes a lot of problems for the patient and for their families and for the general public as a whole. So I based this presentation on the findings and meta-analysis done by the Center for Disease Control USA. And I've taken some background information from the Society of Geriatrics USA and NICE Guidelines UK. So the biggest study that I found was from 2006 to 2010, in which the CDC says that 1 out of 4 elderly people, that is somebody who is above 65 years, will have a fall every year. And the problem with these falls, 30 to 50% of these fall victims will have some sort of minor injury. And 10% of these guys will end up with a major injury. That could be an intracranial injury, or it could be a fracture. And the biggest problematic fracture in this elderly age group is femur fractures, because it carries with it a very high morbidity and mortality. And especially in a country like ours, where alternative medicine is very top high on the list of treatments, like half of the patients who encounter a fall will present to us in the Western medicine setup. When you see a patient, even before you see a patient, what we should think about is what are the risk factors that we have to determine that this patient could have a fall. And when you talk about anything, you try to classify them. So we have unavoidable things, and then we have avoidable things. So one unavoidable thing is, the unavoidable things are the age over 85 years, male gender, and in the US study, Caucasian ethnicity was considered important. And people who had already had a fall, like they have said, if you had a fall, there's like 30 to 50% chance of having another fall within 6 months of time. And then his past medical history that we can't change, whether he had a stroke, he's a diabetic, he has a poor sleep due to things like obstructive sleep apnea, he has limited joint mobility due to arthritis, he's dementic, or he has arrhythmias that cause loss of consciousness, and then sensory impairment, like he has poor vision, he has poor hearing, poor balance, like that. Modifiable factors are the things that we can modify, like the patient's weight and the number of medicine that patient is taking. I will be talking about that later. So polypharmacy is taken as one risk factor for falls. And then the environment where he lives. Do they have slippery floors? They have poor lighting? They have steps that they have to climb every day? Any sort of environmental issue that we can change. And the other thing that we can change is alcohol. If the patient is taking alcohol or is into any other sort of narcotics, those things we can modify. So in any risk calculation of risk, we tend to use risk assessment tools. And the one that the CDC recommends mostly is the MOSE for risk assessment, which I've shown here. There are many other things, like there's a stratified score, and then the American Geriatric Society has their own scores. But anyway, all these scores, they take into account the risk factors that we talked about earlier: his age, whether he has had falls earlier, what are his comorbidities, do they have any problems with walking, posture, gait, any limb weakness, neuropathy, things like that. So according to that, for example, when you take the most for risk assessment score, if the total mark is above 50, it's very likely that there's a 30% chance that you might end up with a fall within the next 6 months. As I told earlier, polypharmacy is a very important thing. The problem with polypharmacy in patients in the elderly age group, that is above 65 years, is that they tend to have a lot of problems. So they tend to go to a lot of clinics. So in every clinic, due to the busy workload, they will see the patient's condition and they will prescribe. And sometimes the patient will forget to tell that he is taking other medication from another clinic. And the doctor might also, that is you guys, when you become house officers and later on medical officers, you and I will forget to ask, are you on any other medicines? So as we all know, all the medications will have their own interactions. They will have their own side effects. And when you take to account the reduced metabolism and elimination and pharmacokinetics in the elderly population, these side effects and interactions are far worse. Therefore, polypharmacy is taken as an independent risk of having a fall in an elderly patient. So the American Geriatric Society has decided on this and given us something called a Beers criteria that is available in their website, that says what sort of medicines are safe to use in the elderly, what sort of medicines we should avoid, and what we should give in very controlled doses. So you shouldn't don't have to really worry about it. You can think about, say, like beta blockers. When you're prescribing beta blockers, if a patient tries to wake up quickly in the morning due to sympathetic blockade, they will have lightheadedness. So in the elderly, it will be worse because they will anyway have autonomic problems. And you give something like a sedative, say the patient says he can't sleep, you prescribe a bit of diazepam, and the patient in the morning will be sedate. And when he tries to wake up, he has to pass urine and try to hurry to the bathroom. He will end up having a big fall and having complications. Then the next thing that is important is why they fall, where, and the mechanism. So the studies, and there had been a meta-analysis done in 2017 that says these patients, they have 30% of all fall victims in the USA said that they fell due to slipping on something. Maybe it's the slippery floor of the bathroom, a slippery rug in the bedroom. They stepped on it and they slipped. So there could be different causes that lead to a person falling. Therefore, the important thing is when you're taking this history and examination, we should identify in the living environment of the patient what caused the patient to fall. And there we can modify that. And there had been some recent studies done with this high-tech gadgets that they determine when a patient is about to fall, when they have low blood pressure, these monitors and stuff. And there's a recent study, just one study done by the American Geriatric Society, that says that these devices could reduce the patient's risk of falling like 20% at a go when they use them. But the problem is the price and availability in a third world country like ours. So, right, when we all have had falls, but we never ended up having big injuries or fractures. So why does the elderly end up having these problems? So the problem in the elderly, what another school of thought is that these falls and the complications are determined by the frailty of the patient. So how can you assess the frailty of a patient? So frailty, the American Geriatric Society says can be assessed by the patient's ability to move and carry on with their daily activities. So a good question to ask according to them is whether somebody can climb up a flight of stairs carrying a grocery bag of goods. If he can do that, then he is fit. So why this frailty is important? Because they have come to notice after the meta-analysis that if you're an active and very active and healthy person above 80 years, your falling risk is same as a 65 years old patient who is not fit. So in this frailty assessment, age is not really important. It is independent of age. So frailty, in calculating the frailty, you take the patient's fitness, the patient's limb power, his ability to move, whether he has arthritis in the joints, and whether he has diabetic neuropathy, like that. It's basically an assessment of their musculoskeletal system and their sensory inputs. So frailty indexes have come up recently, but they are still not widely used. So in the frailty index, they take the medical problems, the functional level, and something called the geriatric syndrome. Geriatric syndrome is what we call the Angepathia in our language. So all these above 65 people will walk in and say, I have back pain, I have leg pain, I can't feel my legs, I'm unsteady, I'm unwell. This combination of usual symptoms, the back pains, the weak limbs, the unsteadiness, is taken together and named as a geriatric syndrome. And worse the syndrome in a patient is, the more frail that patient is. And the other thing is, so we've all had falls. So why does an elderly person fall and end up with having big fractures? So here, the big topic is osteoporosis, or the density of their bones. So as you age, mostly after 65 years of age, your bone tend to lose its calcium and its connective tissues. So they are more fragile. When they hit something, when they are when they are faced with a very high pressure load, they break easily. So then the next problem would be these fragile bones are very difficult to fix, even with the internal fixator. So these patients who are having osteoporosis tend to have more fractures, and then these fractures are difficult to fix, and even when they fix it, when they fall again, they tend to have worse fractures. So it is important to assess whether they have any risk factors for osteoporosis. Right, so now that is the background about falls and elderly people. Now we come to a patient. So when a patient comes to you after a fall, what you should look for is, number one, why, when, and what sort of fall did the patient have? Were you trying to hurry to your bathroom because you had to urinate? Or were you trying to get out of bed? Or did you just sleep on a rug when you were walking out? So we can decide whether it's something pertaining to his medical problems that caused the fall, or whether it was an accident that caused the fall. So if you feel that it was one of his medical problems that might have caused the fall, then you have to go deep into it and find out why he got a fall. So with that, it is very important to go into a detailed past medical history of the patient. So what sort of a cardiac problem they are having. Say he says, I am having, I had a myocardial infarction about 5 years back, and I was in the cardiac ICU for 5 days. Therefore, in that case, you can suspect, okay, this man might be having a very weak heart. So it is prudent that if it is not done within the last year, to go do a ECG to find out whether he has had again MI, or go for echocardiogram and find out what is the current state of his heart, right? So that is the past medical history. So next one would be patient fears. If a patient lives in fear of falling, he might not get into any of the activities. In which end, that he will lose his mobility and his strength of the muscles due to inactivity. So we have to strike a balance between the active state and then preventing falls. And the other thing is we should very thoroughly inquire into the alcohol and other recreational drug use. And in this respect, it is important that if it is possible to meet with the caregiver or a child of the patient to find out what is his current problem, what sort of state he is living in, and then take this whole picture and then examine the patient. So now we are going to examine the patient. Obviously, first thing that we are going to examine is what are his injuries. So I'm assuming that if this patient is unstable, if the patient is critically ill, obviously we are going to go into the ABCD management, as you know, airway, breathing, circulation, and then disability. Now I'm talking about a patient who walks in or is being brought to you on a wheelchair by the caregiver, where you do have time to talk to the patient and find out what is wrong with him. So first, your intent will be to find out what are the injuries the patient have. Does he have lacerations? Does he have bruises? Any fractures that you can clinically determine, or any other sinister features, whether his consciousness is low, whether he is unable to speak, or he's having hemiparesis. Because when we examine the patient, we should determine another important crucial fact. And that fact is, did he fall and get the injuries, or did he get some other illness like arrhythmia, like a stroke, a transient ischemic attack, a seizure, and then fell? So management of those two conditions are different. It's not just going to be suturing a laceration and giving him some pain relief and sending him home. So we have to determine what actually caused the injury from the history and examination. That is why mental state assessment is very important in this patient. Just to have a chat, see whether he can remember the date, the time, who the president is, and where he is, his address, simple things, and do a very simple mental state examination. And if appropriate and possible, we should also assess vision, hearing, and balance before we go into investigations. And then during the examination, a very important another aspect is whether this patient was abused or whether he was neglected. And abuse and neglect is like a patient having bed sores, patient having rashes, patient having unexplainable bruises on abnormal places, like in the face. You don't expect a patient to have a fall and hit his face. So if you have large bruises on the face, a black eye-like thing, and then patient says, no, I didn't have a fall, then you should look into whether the patient was abused, somebody hit him. So in that case, our management would be social services and JMO referral. Now we saw the patient, talked to him, and then we did a thorough examination. And obviously, the next thing is investigations. So current injuries, we should look in. The biggest problems that we can encounter are fractures. So we are going to take x-rays to see obvious fractures. Number two, the most important thing to look for will be intracranial injuries. That is, if you are in doubt of the patient's mental state, or if the patient's current mental condition is deteriorating, you should consider doing a CT brain very early to exclude any intracranial injuries. You should have very low threshold to doing these things. Once that acute problem investigations are going on, it is important to find out what are the patient's clinical reserves are. So you should see whether the full blood count is okay, his hemoglobin levels are fine, his renal functions are fine, eGFR is good, his ECG is normal, no arrhythmias, he's not having any blocks, and then you should check his thyroid functions and his liver functions, and if he's on anticoagulants, his INR. So a systemic investigation profile should be done to find out his current reserves. Then number three, the most important thing would be pain relief. So, okay, as an example, if you take one of the biggest problems a patient will have is femoral neck fractures when they fall. It is very common in the elderly population. And during these studies done by the CDC, they have found, even though that we prefer to give non-steroidal anti-inflammatory drugs such as diclofenac sodium and ibuprofen, they tend to give us a lot of complications. Upper GI problem, bleedings, then you have renal impairment. And when you give opioids, the problem is we are afraid that the patient might have constipation, they have dementia, which can be worse and all that. But actually speaking, they have decided that opioids are better tolerated than NSAIDs when given in appropriate doses. We should always consider dosing. And the number two is in the acute setting, regional blocks, such as if you're having a femoral neck fracture, a femoral nerve block has very good pain control during the acute period. So pain control plays a very important part, which we don't actually see a lot of patients are receiving equally. Right. As you know, a fractured femur can bleed a lot into the thigh. Actually, you can end up with thigh compartment syndrome. So if a patient comes in with a big fracture, especially in the femur, you should always consider whether the patient is hemodynamically stable. They can lose about 2 liters of blood into the thigh compartment alone. So if the patient's heart is okay, no cardiac failure, the renal functions are okay in the past history, you can go ahead with your fluid boluses. And if the patient is spared, you can preemptively transfuse blood. And then, obviously, the next step would be going into surgical correction. Therefore, you must see the blood sugars and correct it, and then as soon as possible, get into cardiac and renal status. And another very important thing in the investigations in a fall victim is anticoagulation. Because for two reasons. One, say you get a patient who has had a fall, he's had a small laceration on the head. But the patient is saying, I'm having a headache, I'm not well, I feel nauseous. And you find out the patient is in clopidogrel. You know clopid is antiplatelet and it can close bleeding. And you should have very low threshold for that patient to get an on-contrast CT brain just to see whether he has a intracranial hemorrhage. Then again, you're planning fracture of femur, you need surgery, patient is in warfarin due to atrial fibrillation. Right, then you need to know what is the INR values and how far I have to correct it. So give a very good thorough assessment of anticoagulation. I just put this slide when you can have, just for you to get an idea, our lifesaver is FFP. So I wanted to add the FFP values. And then these are the anticoagulation that we are going to come across. So quickly, right, next, the head injury problem that I talked about earlier. So if you see a patient who walks in with a small laceration in the head or a bruise around the eye, you say, okay, what happened? I had a fall, I'm okay, I'm fine, no problem. And he says, are you on any medication? He says, oh, I'm taking aspirin and a bit of clopid, otherwise I'm okay, no problem, doctor, I'm fine. Just patch me up, I'm going home. Always remember that these patients over time can deteriorate because of a worsening intracranial hematoma. Therefore, you cannot just suture scalp laceration and discharge an elderly patient. You have to always exclude intracranial injury. You should have very low threshold for imaging, especially for patients who are on anticoagulation, warfarin and clopid. Then again, number two would be, okay, the patient complains of that laceration. You do a CT brain, you do not see an intracranial hemorrhage. But remember, you might see a stroke, a sensory stroke that you would have missed because you didn't check the sensation of the patient. Therefore, imaging should have a very low threshold. Unfortunately, there are not many studies to show the benefits of doing preemptive imaging in elderly population. Right. So if the patient is critically unwell, we know that he's going to get admitted and then he's going to get surgery. But what about the other end of the spectrum? What about the patients who are stable and who doesn't have any big injuries, no head injuries, some bruises all over? So you clinically assess them, you do the risk assessment, you do the most fall scale, and you decide, okay, this patient has a very low threshold. He had genuinely slipped on a rug, so I'm going to discharge him. He can go home. But remember, in this elderly population, it is very, very important to see what are his medical conditions, what are the medication that he is on, and then optimize them before you decide. Because this could be one of the golden opportunities that you're going to get to see the patient's prescription list and correct them for another year's time when he comes back with an even worse fall. Remember, if you see any problems, if you feel the patient is neglected or abused, feel free, and it is a duty of yours to contact social services and inform them. And always try to think and then act upon to prevent falls. Because remember, every patient who has a fall has an increased risk of falling within the next 6 months. Okay, guys, a very short presentation on that. I am open for questions if you have any. Guys,
అయ్యో హరి హరి హరి
any questions? No, I just not.
So I think you unmuted everyone. If you can mute everyone again, they will ask questions.
Yeah, I know. Yeah,
అమ్మే
trying to do that. Sorry. Okay. Right. Yeah, go for it. Tell me. Oh, I'm trying to unmute Tell me, but it's not working. I don't know what's wrong. Tell me, I can't unmute you. I'm opening a chat window. You can type the question. Okay, I have some questions. Right. Danung is asking. Okay, that's okay. Now I think you can hear clearly. Benora is asking, excuse me, sir, age over 85. Yeah, so elderly, we take as 65. 85 cutoff is, we take that their risks are generally higher than 65. So our cutoff age is 65, but anybody who is over 85, all their values are going to go up. Therefore, risk of falling, risk of getting complications, risk of having drug interactions, everything is going to go up after 85 years. So 65, you're elderly. 85, you are really worried. And okay, tell me you can type your question. While the questions are going on, guys, this is a summary. So whenever you see somebody, these are the things that you should look for. Okay, guys. So no more questions. Um, thank you very much. And hopefully we'll have a better experience next time. Until you see again. Good night.